Okay, well, it's 8:30 and I think we have a good number of participants on board, so I'm going to go ahead and get us started. I'm very excited to introduce our 4th annual Humphreys Neuroscience Research Day today. There's a fantastic lineup of research presentations from our current trainees, and we're very much looking forward to a plenary presentation from one of our former trainees, Dr. Serena Orr. This research day will begin with a Grand Rounds presentation with a special guest speaker, and I will turn it over shortly to our Chief of the Division of Neurology, Dr. Asif Doja, to introduce our guest speaker. I would first like to acknowledge that Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. So as this is the 4th annual Humphreys Pediatric Neuroscience Day, I would like to begin with a few words about our very own Dr. Peter Humphreys. For those of you that don't know, I'm going to give you a little bit of biographical history. Peter graduated from medical school at McGill University, went on to pediatrics training at Boston Children's Hospital, followed by further training at St. Mary's Hospital in London, in the UK. He did further training in neurology at the Montreal Neurologic Institute, and he joined CHEO in 1979, where he was founding head of the Division of Neurology in 1979. And his legacy has continued ever since. As a specialist in developmental brain disorders, he established the first Canadian clinic devoted to patient care and research for Rett syndrome. His research publications have focused primarily on Rett syndrome, cerebral palsy, and fetal hydrocephalus. And he is one of 2 investigators for pediatric stroke studies created under the umbrella of the International Pediatric Stroke Study. In recognition of Peter's great work and contributions, he was the recipient of the 2021 Canadian Association of Child Neurology Henry Dunn Lifetime Achievement Award. Peter Humphreys, or I should say the Humphreys Pediatric Neuroscience Day honors Dr. Peter Humphreys for his significant contribution in the field of pediatric neurology and his dedication to his patients and research. Dr. Humphreys retired in 2017, but is still active in teaching and academic activities, ensuring that his legacy of excellence continues. And we thank him very much for that. With that, I'm going to turn it over to Dr. Asif Doja to introduce our guest speaker.
So, thank you very much, Mona. So I'll introduce Dr. Hershey in just 1 minute. Just want to give people an idea of the day today. So we're going to have the Grand Rounds lecture by Dr. Hershey. Subsequent to that, we're going to have a talk, as Mona mentioned, from Dr. Orr, who's one of our past trainees, who's doing a significant amount of headache research in Calgary. Then we'll have a short break between about 10:30 to 10:45. And then I'll hand the reins over to Dr. Pohl, and we'll hear some brief research presentations from trainees working in pediatric neurosciences at CHEO, and we'll hear some of their presentations. We've asked Dr. Hershey and Dr. Orr and Dr. Humphreys, if possible, to provide some feedback to our trainees, just a few short lines, if they're able to stay, to give them some feedback. So, and then things will wrap up around 1 o'clock. I know some people may have other meetings, and if you have to go in and out during the day, that's totally fine. You can just log back onto the Zoom. So without further ado, I did want to introduce Dr. Hershey. Every year we've had, for the past 4 years, we've had significant pediatric neurologists present, people who really made their mark on pediatric neurology as a practice. We've had Carter Sneed, Carson Bonneman, and Brendan Banwell. And Dr. Hershey is definitely in that category in terms of people who've been involved with migraine and headache research in the pediatric population. Dr. Hershey received a Bachelor of Science with highest distinction in biochemistry from the University of Iowa, and then did his MD and PhD program at Washington University in St. Louis, Missouri. Then after he did his MD and PhD, he started residency in pediatrics, neurology, and child neurology at the St. Louis Hospital and Barnes Jewish Hospital in St. Louis, Missouri. He then joined the faculty at Cincinnati Children's Hospital, a medical center in the University of Cincinnati College of Medicine, where he became the director of the Cincinnati Children's Headache Center and the endowed chair and director of neurology there. He is a professor of pediatrics and neurology at the University of Cincinnati College of Medicine. Again, major headache research being done in North America. You see Dr. Hershey's name often attached to it. His research interests include the improved diagnosis and treatment of childhood headache disorders, characterization of outcome responses, studies in new pharmacological and non-pharmacological treatment regimes, and the genomics of migraines. He has been funded from the NIH for a wide variety of projects since 2003, including collaborations with Dr. Scott Powers at the CCHMC. So it gives me great pleasure to welcome Dr. Hershey here today. His talk will be Migraine in Children and Adolescents, from the Basics to What's Next.
Thank you, Dr. Dozier, for that kind introduction, and thank you for inviting me to this very honorable lecture series. It's nice to meet you all, at least virtually, and nice to meet you, Dr. Humphreys. I'm going to, as I said, the title discuss sort of migraine in children and adolescents, and trying to do all this in an hour is quite limiting. So I'm going to focus on a few areas, but hopefully leave a little bit of time for any questions and answers if I don't cover something of interest to any particular person. On this slide, just list my disclosures. I'm involved in quite a few different grant supports from both the NIH National Institute of Health, as well as locally, and I guess with my collaboration with Serena. It's an honor to be actually having Serena follow me as one of my former fellows that we're working on some Canadian funding too. So it's nice to have a lot of sort of pots on the fire. I will be talking about a few of the pharmaceutical studies, so there's a little bit of interactions there, but it's more in the general concept of how to fit management and treatment of children and headaches. So the objectives of today's talk is we talk about, in a simplified way, the diagnosis and evaluation of children and adolescents with migraine, and then try to focus a bit more on the new treatments that are approved for adults, how we may think about in the future, and that future may be happening right now, how to incorporate them in children and adolescents, and then what that future holds for additional treatments and possibilities. One of the slides I've been putting in most of my recent talks is, before we get started, is I call my nomenclature slide. And as I've been giving these talks for the last 30 years or so, I've realized that there's some misperceptions in there. And as time's gone by, I realize those misperceptions are tainting how we understand things. So first and foremost, I think we should think of migraine as the disease, not as an event. Many people will say, I had a migraine or I have migraines, and that's really not the proper way to treat things. As I tell patients, you say you have epilepsies, you say you have epilepsy with seizures, or you have asthma, you don't have asthma, so you have asthma with attacks. And similarly, you have migraine, and the disease can be associated with one of the episodic disorders, which is headaches. But for those of us that take care of children and adolescents, there are also other episodic symptoms that we now recognize also exceed into adults that may be part of this larger umbrella of a disease migraine. The other thing is that really all events appear to be episodic, meaning that they're not there all the time. So if they do have motion sickness or car sickness, which is one of the periodic symptoms or episodic symptoms that are associated with this disease, they may not get it every time they get in the car. And similarly, they don't get a headache every time an event happens, although we do have kids that do get up into that continuous range. Second sort of bullet point is that it's migraine. It's not children and adolescents are an adjective. So it shouldn't be, it's not adolescent migraine or pediatric migraine. It's migraine, and it just happens to be that the population that we look in is children or adolescents. And the reason I think this is an important understanding is that if it really is a disease that spans the lifespan, and trying to fractionate it at an odd cutoff of, say, 15 or 18 or 21, and saying something different just because of the age of the child doesn't really recognize that. Now, I'm going to show a few slides of why the developmental aspects that underlie the nervous system may be contributing to the variants we see, but that may not be the disease. It may be the underlying biology of developmental neurosciences. And then finally, and then I throw this in just because our pharmaceutical colleagues have sort of been pushing this down our throats to try to separate chronic migraine as a subcategory, which it is, but then the corollary is to call something called episodic migraine, which is really not chronic migraine. There have been in another talk that we actually had a nice debate with David Dodick, who fellow Canadian of you, that we sort of both agreed that we probably need to change this somehow. I took the part of the debate that we should just eliminate the term chronic migraine completely, and he said reduce it down to 4 per month, just so we can get better coverage. So moving on to just focusing on migraine, sort of using this cartoon to sort of divide things into different aspects. But if we think of migraine, why should we study migraine? From various studies, we know it's quite common across the ages. In young children, it may be as high as 4%. As kids get a little bit older, it can get to 10%. And one study of older teens showed it was up to 28% of that age group tended to have at least something that appeared to be migraine. As they get into adults, there's a shifting prevalence to more and more women versus men that does occur during adolescence. It does appear to strongly be a genetic disease, and I'll show these a couple slides that support that component to it. But even also important, it's quite financially impactful. It can cause lost school days, so kids aren't having those learning opportunities. Some of these are old dollar amounts, but you can see as the time goes by from 1998 to 2016, the cost of treatment of these different components has continued to go up, at least in US dollars, and that does sort of express itself worldwide. Speaking of worldwide, in the 2015 Global Word Burden of Disease, really looked at and characterized the different most common diseases, and this is all diseases across the world. The one thing I like to highlight this, and I sort of gray out everything else, is where migraine falls. And you can see as we start to get into the teen years, it really rises to the one of the top 10s and persists that way all the way through the mid-60s. So it really is a disease that spans the lifespan, and the earlier we can recognize it, interact with it, the more potential we can change the direction of the disease. If we focus just on neurological diseases, and this is a very nice colorful graph, but really what it's trying to demonstrate is all the various neurological diseases and the global burden of those neurological diseases. In early childhood, of course, there's a lot of different potential infectious disease processes that contribute to the world, but if you can get past 5, most kids tend to be fairly neurologically healthy. But if we expand this a little bit to the age interest we're looking at, what we can see is in the 5 to 20, 25-year-olds, we start to see this growing number of blue lines or blue bars with the underlying orange and red. The blue is migraine, the orange is medication overuse, and the red is tension type headache. What we can really see for that combination, really starting in the late teens, through most of the productive years, or at least into the 40s, it's number one, and it continues to be a major factor until we really get through later life, where many of the other neurodegenerative diseases start to have an impact. So if you think about that in the kids' time, when they're really trying to learn a lot, they can be quite impaired. So thinking of migraine and why we study it, I'm going to focus on some of these aspects. This is my way of thinking of how we can think about a disease, starting at the disease characterization all the way through the final progression. And we're going to focus a little bit on the disease characterization and what's underlying the pathophysiological components of that. I took this slide out of a PNSA article, and if it's sort of see it's a movie on the right. It's graphic, really presented on the left. And what this is really showing is the development of the brain. Part of the reason I bring this up is there is this progressive development that does tend to be more central and progress, with the prefrontal lobes being one of the last areas to develop. And this is more of a thought concept to think about as we're going through these developmental ages from age 5 to 20 of the brain. And that's oftentimes when we're starting to see more characterizations of the headache features. Another way to look at it graphically is this. Now, the axis here is somewhat compressed as you get older, but in the younger ages, you can see pre-birth and then on to birth, many different aspects of brain development, with one of the last aspects of cortical development being the prefrontal cortex, which corresponds to some of the changes in seeing and hearing, possibly an explanation of why younger children don't notice as much the photophobia and photophobia of migraine. And then the receptive language component, which comes into the developmental aspects of maybe not being asking the right questions. As they get older into their teen years, that's where higher cognitive functions. I think this is potentially important as we discuss the various components that balance out the sort of mental health and logical health issues, as the medial prefrontal cortex and the lateral prefrontal cortex have different roles, and that balance is ongoingly being developed during adolescence. So with that, understanding the brain's rapidly changing to this stage, why focus on just looking at these kids? Well, one reason is the brain's very plastic also at this stage. So we have the potential, if we can recognize migraine early, to have a lifelong influence. It doesn't say that as we get older we can't change. It just takes a lot more energy and effort to change. So changes can occur as people older, but it's a bigger hill to climb. So how does this usually oftentimes present or can present in young kids? This is one of my mentors, Dr. Prinsky, who sort of inadvertently got involved in migraine. He was seeing quite a few patients, and one of the people, the admins he worked with, said you should write it up. So he started to recognize that migraine itself is much more than just the headaches, and called them the migrainous variants that did occur, or the recurrent symptoms. Dr. Lanzi in Italy expanded this much further and really found that in addition to, if you looked at people that had migraine or later developed migraine, which is the second column of numbers, you can see that they have a higher frequency of a lot of these different episodic disorders, really suggesting that it's not just a pain disorder, but there's a lot of underlying other neurological symptoms and potentials. If we look at how this progresses and think about the developing brain, this just looks at the epidemiology of the periodic or episodic syndromes as they develop. Early on in life, there's a lot of recurrent abdominal pain, which may be one of the first manifestations. Even before that, there may be some colic pain or episodic colic that can present. If we expand this graph a little bit to take out the abdominal pain, what you can start to see is what's something that's been labeled abdominal migraine, or in males and females, shown in the blue and the green bar, as well as sort of a steady state of cyclic vomiting syndrome. This does seem to increase fairly abruptly in the toddler years to young children years, and then decline fairly rapidly as kids go through childhood. And the reason I bring this up is now if we overlay the epidemiology of migraine, what we can see is that really what we call abdominal migraine and a lot of these recurrent abdominal symptoms that are presented early start to disappear at the same rate of which the headache's presentation of migraine occurs. The hypothesis postulation I have here is partly that goes back to that expressive language, prefrontal cortex development, and possibly to a little bit of our own blame of not asking the child, do you have a headache, when they complain of recurrent abdominal pain? And that asking the right questions and doing the right examination may help us reveal this earlier on. So if we sort of look at this in terms of that pathophysiological component and buildup, what we can see is that the rate at which the brain's developing, whether we look at it in a cartoon graphic or we look at it as the different areas of the brain that are developing, we can see that a lot of this early progression corresponds well to the developing brain. So how do we approach this? Well, this gets into the diagnosis, and I think understanding the pathophysiology leads to this diagnosis, is that we really need to do, and those of us that take care of children know this, is the patient really is the child, not the parent. In headaches in particular, since it does appear to have a genetic component to it, the parents may have their own likely biases that contribute to this. So it oftentimes takes that directed nature to ask the child specifically about their headaches and give the parents to weigh in a little bit later. To do this, it does need to be developmentally appropriate, and sometimes things like drawing tools, or what we've used for a long time in Cincinnati is a semi-structured interview process that helps them guide through the steps. And we can oftentimes say, we'll talk about that a little bit later, but let's focus on this part first. The other observation is that children in general are healthy, unlike adults, where there's a lot of comorbid conditions. that contribute to it. There may be only a limited number of comorbid conditions, but we'll discuss a little bit there. On the other hand, though, children can be severely impacted. We developed Ped-Midas to address this. It's evolved out of Midas, or the Migraine Disability Assessment, to really try to look at the impact, not just in school, but also in social and home activities. So that's how we try to focus. Now, what is, talk to us a while about migraine, how do we classify it? Well, currently we're using the 3rd edition of the International Classification of Headache Disorders. This is the subcategories that all fall under migraines. Hopefully by now I've convinced you migraine isn't just a headache, but there's a lot of other things that go on. And this really breaks out into our classification schemes. It is a hierarchical scheme. So the overlying umbrella is migraine, and these are all the first level breakouts of that. It includes migraine without aura, migraine with aura. Chronic migraine can have complications, and we see quite a few kids with status migrainosis. And then if they don't quite fit everything, it can be probable migraine. And we do include the episodic syndromes, formerly called periodic syndromes, in this area. One of the important things we put together in the 3rd edition, though, is that you don't have to focus in on just one. You actually include everything that a patient has. So if you see somebody with 20 headache days per month, 5 of which they are preceded by an aura, and they fit the international classification, they may have migraine without aura, migraine with aura, as well as chronic migraine. If we look at just the specifics of migraine without aura, the most common in these areas, required to have at least 5 attacks. That's over the past year. So they don't have to be that frequent. The duration is modified slightly for children, that it's 2 to 72 hours. But most importantly, we do include sleep. So if a child gets a headache at 6 or 7 p.m. at night and then goes to bed for the night, wakes up the next morning at 6 or 7 and is headache free, that's really a 12-hour headache, not a 1 or 2-hour headache that is going to fall asleep. I'll get to why this is important in a few of the characteristic slides in a second. And then if we look at the characteristics, it's usually unilateral. This is the weakest one for children. Oftentimes children are bilateral, but a pulsating quality. They may not use the word throbbing or pulsating, so demonstrations may be necessary. A lot of people get the misconception that it has to be a severe headache, and in fact, more people have moderate headaches that fit this criteria, and then it may aggravate routine activity. You need to have either nausea and or vomiting, or both light and sound sensitivity. And for the light and the sound sensitivity, we do allow parental observation. So these are the specific notes, comments for children. The only point of the entire criteria, the ICD-10 criteria, that makes an exception for children is that the duration of the headache can be shorter in children under age 18. The rest are comments. So children do tend to be more bilateral, but we didn't change the criteria. We do allow parents to infer the photophobia and phonophobia. So a child may say, no, noises don't bother me, and I'll turn to the parents and say, do they tell people to shut up, I've got a headache? And they'll say yes. So oftentimes the kids may not notice it quite as clearly as the parents have. Other than that, the only other comment is an aura, that it may be bilateral also in kids. So I'm just going to show you a little bit from our database that then shows the different characteristics and how they evolve over time. We've seen over 22,000 kids with headaches, and this shows how they evolved a little bit with time. If we look at the frequency of headaches per month, and this may be more of a reflection of how long they've had the disease process, we do see that many of the kids that we take care of start to exceed that 15 headache days per month by their mid-teens. So many of them have very frequent headaches that are very impactful for their life. Again, this is a selection bias because they're coming to see us. If we look at the different characteristics I just ran through, we can see that activity does contribute, and actually in change in activity worsens, does occur quite frequently in these kids, although it tends to be one of the lesser things. I think this implies that kids remain very active, or try to remain very active even when they're having a headache. One of the boys I just saw yesterday said he was a wrestler, and he said, it's never going to stop me from wrestling, because that was his passion. So kids sometimes force themselves through things even with pain. If we look at the associated symptoms, one of the things that we do see here is that the nausea and vomiting starts to diminish, especially the vomiting, as we move away from those abdominal symptoms. Conversely, the photophobia and phonophobia steadily rise. I did superimpose something that's not part of the criteria, but that we've observed quite frequently is that the lightheadedness symptoms seems to be one of the most dramatically changing features that occurs across these developmental ages. If we look at the location, this is where you can clearly see that transition from bilateral, really frontal to bilateral to unilateral that occurs, although even by the late teens, they remain that bifrontal location. And then if we look at the duration, and this is why I said if you do count sleep, we ask the question, the average headache duration, the longest and the shortest, and you can see kids as well, even the youngest kids can well fall into the criteria. So looking at all this, and we overlay that again thing I've been showing before, that with exercise, you help the brain development, which shows on the left, but a lot of these changes correspond directly to the changes we're seeing. If we look at why, or what's happening in the population, this looks at migraine epidemiologies. Going back to what I showed in those periodic syndromes, we can now tease it out a little bit further. And in the slide on the left, the green line shows the total population, but if we break it into the boys and girls, we can see the boys develop fairly quickly into the headaches remain steady, whereas girls continue to climb through puberty. The graph on the bar just shows the difference, how long it takes for kids to come and see us. So what it really is showing the age of onset, which is in blue, and then separated in orange is how long it took to see us. So it does show us that the older the kids get, the longer it takes for them to come and see us. And then the final graph I'm showing here on the right is really our population sort of sees, and how during the point I wanted to point out is the green bar that really shows the rapid rise that does happen in girls. So that's the characterization. Why does this happen? And I'm not going to go through the entire puzzle piece here, but I do want to talk about a few features here. One thing that has been observed is that the brain of somebody with migraine is hypersensitive. And just one of the better graphs I think that shows this graphically is the passive oddball auditory effect. It's simple to understand. It's basically you're giving a fairly obnoxious noise and then looking at where it becomes bothersome. If you look at controls, people that don't have migraine, even when they're not having a headache, fairly quickly can attenuate to that obnoxious noise. Whereas people that do have migraine, it seems to get worse and worse, suggesting the brain potentially is hypersensitized. One of the ways that patients recognize it is something we call allodynia, or that development of an increased sensitivity to pain stimuli. We know this is due to a potential central sensitization process, and it may be dependent on how long you've had headaches as how long the headache has been going on. Something we call activity dependent, which happens early on, and then activity independent that progresses. This isn't a new observation, and Nine and Matthews demonstrate in adults that depends on how long you've had headaches, about how much allodynia. One of the things, and why this led to a little misperception, I think, for kids, is that it really showed that the perception in adults is you had to have persistent headaches for at least 10, 15, 20 years before you developed allodynia. If it's 15 to 20 years to have headaches, and children don't present with headaches until they're 8, 9, or 10, then by that definition, it was assumed that kids cannot develop allodynia. It also is a frequency dependent and more frequent. So we took that as a challenge and started to ask our kids about different questions about this increased sensitivity during a headache. And what we found is actually the kids, yes, they do get allodynia. In fact, they develop at a much more rapid course. So even 30% of our 5 and 6-year-olds will have it, and by the teens and the young adulthood, nearly 2/3 of our kids and young adults are reporting these symptoms of allodynia. One of the questions that has come most recently, and Dr. Richard Lipton addressed this in adults, is this development also associated or co-associated by a frequency basis with the development of comorbid symptoms? All the words are small in this graph. I tried to color code it in different grouping areas. These were the comorbidities he looked at, which he defined as allergic areas was one grouping, sort of abdominal motion sickness. So the allergic symptoms are in green, motion or abdominal symptoms in blue, behavioral or mental health problems, including anxious or anxiety, in red, head injury, which often comes to be a triggering factor, and then in yellow, and then in purple, the sleep component. So I took these categories and asked our kids, or actually mined our database, to how this was occurring. And you can see that many of these comorbid symptoms that he classified as contributors in adults were developing and increasing across childhood. If we put the whole group together, you can see that some of these do pop out fairly high. Many of our kids do have allergies. Allergies may be, as I talked to, not a cause or a trigger of headaches, but it may be that when your body's being physically stressed by allergies, it makes it easier to have a headache. In the blue, motion sickness is one of the most common one. In the red, feeling anxious or anxiety is most common. And then a lot of our kids, and shown in purple, have difficulty sleeping. One of the other effects, and why does this happen, and why does we see this transition from boys to girls? Could it be puberty? To focus specifically on girls, what we did is we asked nearly 1,000 girls between the ages of 9 and 18, were they having monthly headaches? Did they have their first period, and how they corresponded? And in the upper right bar, what you can see is that girls even 2 to 3 years or more pre-pubertal started to notice a monthly headache to their pattern. This is shown in the black bars. The white bars actually show the development of when they start having their period, and it does start to level off in the mid to late teens. So there's a clear hormonal effect that may be presenting way before the girls have their first period. We also ask them when that headache occurs, and it usually is 1 to 2 days before the period starts in those girls that it started. Moving on to genetics as a component, we do ask about a family history, as is important to do, and then I took the classical design here of putting red or pink and as the females and blue as the boys, but one of the things I think this does highlight, whether you just ask about headaches or you ask specifically about disease migraine, the moms actually were the most common contributor, although the dads aren't completely off the hook. And so oftentimes I will tell the kids, who do you get to blame? And they can understand that this isn't just their problem, it's a family genetic problem. Again, this is an old study, but actually I think it's one of the best ways to explain and think about it. So this was way before as we have the United States HIPAA or Privacy Acts. So we're in Sweden, they were able to track births, and they tracked a group of twins, assessed them when they were 8 to 9 years old, and asked about, at that time, the ICH1 criteria. They were broken fairly equally between monozygotic and dizygotic boys and girls, as well as opposite sex. So they had 1,000 kids in this cohort that they were able to evaluate. They came up with a model. So T1 is a twin 1, T2 is twin 2. The C is the shared environment, the A is the genetic load, and E is the independent environment. And these are the results, and I'll zoom in on that a little bit because it really breaks out as you can think of as a percentage component. And what we really see is that the genetic load seems to be about 2/3 of it, and the environmental load is about 1/3. So we can't change their genetics, at least not yet, but we can change the environmental influence, and that's one of the ways we can modify things to make things better. When I do my genetics talk, I go through this in much more detail, but I did want to think about some of the polymorphisms that have been currently identified and how we can think about the medications we're using, the medications we're developing, and the devices that we can potentially use. So in this study, they really broke out at this point, nearly 40 genes. We're now up to 120 different polymorphisms or potential polymorphisms into 4 major groups. The more we find, the rarer they are. So the transition to 40 to 120 sounds like a fairly large jump, but many of them still remain in these categories. But they broke it down into neurological, vascular, hormonal, and inflammatory. And I'm just going to show a couple tables of each one of these. So if we look at the neurological ones, you can look at your favorite gene of choice, but down the right column, or excuse me, the left column, you can see several of the genes listed. I did circle a few. One is the serotonin genes. Many of us are aware and have used triptans for a long time, and there are several of the serotonin genes that seem to be related to polymorphisms, variants that occur. The other one is dopamine, and it's been even longer known since the 1970s, using dopamine antagonists like prochlorperazine or metoclopramide in the emergency room setting as one of the more effective ways to stop an attack. And there's multiple different genes in the dopamine component. We go move on to the next group, which is I'll expand that a little bit, the vascular genes. It's oftentimes and historically was thought that the cause of the headaches was due to vascular changes, and it was thought to be a blood vessel disease. Well, there are vascular genes involved. There's several listed here. Several, we use ACE inhibitors are used much more commonly in Europe as one of the preventative agents. One that I like to point out in particular, though, is MTHFR, or hydrofolate reductase. This has now been associated in adults that deficiencies in folate may be associated with an increased expression of aura. We are finding, and this is outside the level of this talk, are finding that about a third of our kids are low in folate. The way I like to think about this is if you have a polymorphism in your MTHFR gene, you're unable to incorporate and use folate as effectively, so you may need higher levels of folate to function normally. So seeing that MTHFR is involved, and now knowing that it appears to be involved in the presence of aura, means those people especially may need to have their folate levels checked. We look at as I showed, that girls do tend to worsen as they go through puberty. And so several of the genes that have also been noticed are involved in hormonal development, including estrogen receptors as well as progesterone receptors. And finally, many of us will use NSAIDs or non-steroidal anti-inflammatories as the first-line agent for treating kids with headaches, and several of the inflammatory genes, including COX-2 inhibitor or COX-2 gene, have shown polymorphisms at a variety of different levels. So the nice thing, and reason I like to go through those three categories, is many of the things we've used in the past align well with what we're finding in the genetic polymorphisms. And finally, discussing what's going on in the brain. And this is a study that we did using a magnetic encephalogram machine. Without going through the study in full details, the simple component to it is the kids wear a headset, and then they hear a click in either the right or left side, and are asked to tap their fingers correspondingly. The reason we bring this up is we can compare kids that did not have migraine as disease compared to kids that did have migraine, and these were actually during a headache attack. And on the right picture, you can see that most people incorporate a small area of the brain to do this simple finger tapping test. But if you look at somebody with migraine, it takes much more brain activity. And in a separate slide, I can show that it takes about twice as long. So when kids tell you it's hard to think and hard to do their schoolwork because they're having a headache, it's not because they're in pain. They actually have to utilize a lot more of their brain. I'm not going to talk as much about the pathophysiological changes that occur. It's a separate talk that really does suggest that our not treating headaches can have some long-term consequences. But I do want to move on for the purpose of this talk to talk a little bit about treatment. If we talk about treatment really requires a multimodal approach. And there's some few keys about this. As I've said before, in the evaluation setting, the child is the patient and they need to be central. But beyond that, they need to also be involved in the decision making. Many parents, a parent myself, we feel like we need to help guide our children and adolescents, but there's some good growing evidence, especially in the pain world, that if the patient chooses their choice and are actively involved in the decision-making process, the outcome, the expectation is actually greatly improved. So as clinicians, we can leverage this by actually making sure that the child has it in that engagement. And what I oftentimes will say to kids, and this goes down to even 5- and 6-year-olds, is ask them what they want to do. And I said, you can call a friend if you want to ask your parents for their advice, but I want you to choose. And I do say your parents do have some veto power. So we do break the treatment into acute treatment, so what to do when you're having an attack, and preventive treatment, how to prevent having those attacks in the first place. Before I discuss that, and this again is about a 10-year-old study, but it's one of the better characterizations of the level of evidence at the time that continues to show that we lack much of the information of how to effectively treat children. If you look at this study, this table, and look at the fourth column, it grades the evidence. And the thing you can see here is there's really only two lines, ibuprofen, as well as suprachiasmatic nasal spray, that had grade A evidence, meaning they had enough evidence to say we could make a decision. We can break this out a little bit further and tease these out in terms of pain relief, and we don't see a lot of strong pluses here. We do see it for acetaminophen, for ibuprofen, and a few of the triptans. If we look at prevention, and there the columns are changed, but it's the second to last column, we sort of see the same thing. Very little evidence that's really at grade A. So to jump forward to 2019, A series of guidelines were developed to help with this. I was involved with all of these, but one of our first one was how do we do studies better? If we have all these gaps in our information, we need to figure out how we can do studies better. So Ishak Aberfay and I were lead authors, along with Christina and Christina Tesroli, to try to come up with a sort of a recipe book about how to do a prevention trial in children. At the same time, both the American Academy of Neurology and the American Headache Society were developing acute treatment guidelines. And I'm going to go through some of those in a second as sort of the foundation here. They were co-published both in the Green Journal as well as the Headache Journal. And we also developed at the same time prevention guidelines. So these guidelines all exist there. I'm going to show those briefly and then show some of the highlights of those in the next few slides. So from the acute treatment guidelines, what we really recognized is what's key is we need to focus on early treatment. This goes back to that development of allodynia and that observation, especially in adults, allodynia, that if you treat early, you have over an 80% effectiveness, whereas if you wait, it's less than 30%. So kids do need school notes. They do need ways to be able to treat when their headache starts in school or when they're out on the sports field. You need to choose the most appropriate route of attack if they can't swallow. And I'm going to talk about one new route that we're actually finding a lot of our kids are really accepting well. And then the other observation is try to avoid triggers or really balance a healthy lifestyle. And then we always need to discuss the risk of medication overuse. This is the summary table. And the first thing, and I know it's small print, but the first thing I want you to notice is that many of these areas are empty. And I think that really is the highlight here, is that we really continue to lack evidence to fill in this table. And so that does give the opportunity for the future to start to fill in this, to have more and different opportunities. In the individual sections also, there's not many options. To help with this acute treatment guideline, we developed a guest editorial to sort of guide people through what the current foundation is. And really the first line is to start with an NSAID. In this particular case, the best evidence is for ibuprofen. If the NSAID doesn't work, then you add a triptan. If that triptan doesn't work, you consider another triptan. And then if they do have significant nausea or vomiting, consider antiemetics. So that's where we're at now. Where are we going to be? So if we look at what's on the horizon, for adults, there have been GPANs. Currently in the United States, there's 3 that have been approved, 2 for acute treatment and 2, because the rimegepant's been both used for acute and prevention, for preventative treatment. There's 1 Ditin, but there's also development of other areas of the brain development, including PCAP system, and most recently devices have also been added to this mix. So if we look at starting with the GPANs, and I took this as a review article because it covered all the GPANs that were active at the time. So this was a 2000 article. And this broke down the GPANs and their level of studies. So it really does mention those 4 that I showed on the 2 slides ago. The rimegepant, the ubrogepant, the vasepant, which is not yet available, but is a nasal form, as well as the 2 preventative agents. It's hard to read this slide and all the components, but you can see most of them are in phase 2 or 3. So I took this data and just made a simple graph. So this breaks out that same data from that table to the various GPANs. So rimegepant's been the most studied. You can see it's had 3 phase 3 studies. The takeaway I really like this, in the phase 2 studies, you have to always call in question, they aren't as powered to be a full study. So the phase 3 studies really give us the best evidence. And if you look at pain freedom at 2 hours in adults, it really is only about 20 to 25%. So it's not a home run. It's not out there where it really should be. So there's still a lot of opportunities there. If we look at the placebo effect, we can see in these studies, pain freedom was quite low. We can also look at prevention, and in prevention, we look at the number of migraine day reduction. Again, migraine days is a little bit of an oxymoron. It's headache days in somebody that has migraine. But even though these were statistically and led to an approval, you can see the improvement was only about 1 or 2 days over placebo. Or another way to think about it is 80% of the effect of what we're seeing is due to placebo. The other new agent is plasmoditin, or one of the ditins, which is a 5-HT1F, so sort of a triptan-like agent. It does have the complication that it does make people a little bit sedated and should be recommended not to drive after they take it. But if we look at these results, and what we can see is that it also falls at about 30%. So as these agents start to be evolved and developed, I think the conclusion is we probably will still start with an NSAID, probably still next in line may use a triptan, but then after that, we may come in use of gepants or dietins as they start to be studied and fully understand. I also throw out a caveat there that given the fact that the separation in adults was quite minimal for both the acute effect and the prevention effect, and due to something I'll talk about later, the placebo component in kids, we may not actually find separation in adolescents. And so that does put things at a bit of a risk. One of the other new areas, though, that really comes on is the devices. I show 5 of them here. One of them is a lamp that actually seems to help calm the brain, especially at the thalamic center that Dr. Rami Burstein has actually shown first in his lab, and now has helped develop this alley lamp, or this green lamp. There's also 3 or 4 different acute treatments. One of them, in the bottom right corner, actually the company went bankrupt and new investors are trying to bring it back up. But the other 3, the cephalate device, I know because Rena told me that when she was a fellow here, was available over the counter for you guys much earlier than it was for us. But this is something that kids wear on the forehead. But the other 2 devices, the middle one on the right is called Nerivio, which uses something called conditioned pain modulation, and then there's the GammaCore on the right. I'm going to focus a little bit just on the Nerivio device, mainly because it has had the best adolescent studies. The others, the Nerivio and the GammaCore in the United States have been approved down to age 12, but the GammaCore is more on the observation that was well tolerated by adults, and the studies really haven't been done. But the studies have been done in children and adolescents, mainly adolescents, for the Nerivio, or the conditioned pain modulation response. We call it an REN component, so remote electrical neuromodulation. The way the device works is you wear it on your arm and you control it with a smartphone. So if we look at what happened, and I was the lead author on this study, was sponsored by Theranica, so from a complete openness there. But it does look at how kids responded. And if we look at a single tack or multiple tacks, pain relief occurred, meaning the headache was better in about 2/3, but we saw pain freedom in about 1/3, or 30%. Very similar to those previous graphs I showed on gepants and dietins. If we then look at consistency across attacks, and this looks compared to medication, we did find that the devices worked equal, if not better, than medication. Now, this is a little bit of a bias because these were the patient's choice of medications and they hadn't been given advice on how to use medications properly. Main reason I do this is I think this is an area where we can, as those that take care of children and adolescents, can utilize the adult data as a comparator. So if we look at the adult study that led to its approval, which was a sham-controlled study, we do see, again, about 2/3 of the adults had pain relief and about 1/3 had pain freedom. I then superimpose on the right the results I previously showed of what happened in adolescents. And we can see the numbers look about the same. So we can expect the efficacy to be about the same, but the problem we run into, and I'll discuss in a bit, is the placebo component. So moving on to prevention guidelines, the keys here is the majority actually failed to show efficacy. What did show efficacy was lifestyle and behavioral factors, so basically telling kids that they need to take good care of themselves. And that shared decision was, again, an important factor. This is just the breakdown of all the studies that were looked at. And the takeaway here is there were nearly 2,000 studies examined, but only 15 had enough evidence to actually draw conclusions. So although there are lots of studies and courses and case series out there, well-controlled studies remain somewhat limited. A similar graph to the acute treatment, this is the preventative treatment, and similar observation. There's many gaps. What was clear from our recommendations is really the combination of amitriptyline and cognitive behavioral therapy appeared to be the most effective treatment. It's the far left column there for the most part. So what's on the horizon for prevention? Well, the CGRP antibodies have sort of taken the headache world of it by storm. They now are working on studying them in children and adolescents, but a little bit further down the road are the CGRP antagonists and potentially the use of devices. GammaCore itself has been shown to be prevention, and others are starting to be looked at that way. Before I jump into that, I'm going to really discuss our CHAMP study. This is one of, not the largest, independent pharmaceutical company studies done in children and adolescents, where we looked at how effective the old medications, amitriptyline, topiramate, and comparison to placebo were. These results were published in the New England Journal of Medicine, and to jump to the punchline, this is what we saw. And the real key takeaway here is no matter how we looked at it, from the primary outcomes to the most observed data, so those people that had complete data sets for us, is that the everything worked. So amitriptyline worked, topiramate worked, but so did placebo. The reason I wanted to show this as an introduction is to show where we sit in the current landscape. If we look at the old medicines, we look at the adult study, which is very old. If you look at it, 1979 is when the amitriptyline studies were done. You can see the efficacy for amitriptyline in adult at 55% aligns fairly well with the efficacy that we saw in the CHAMP study. So it's not just because it's an old medicine doesn't mean it doesn't necessarily work. If we look at topiramate, similarly, and I tried to line these graphs up appropriately, you can look where topiramate falls. And similarly, the adult topiramate study aligns fairly well with the CHAMP study. So what about the new agents? So if we take the adult studies that have been done to date for the CGRP antibodies and align them with our CHAMP data, in this part, again, the graph sort of got squeezed a little bit so that you could compare the two axes. And so if you just visually look across the board, compared to our CHAMP studies, actually the adults' response to the CGRPs weren't quite as well. Now, this is somewhat comparing apples to oranges, so it's not a direct comparison, but it can give us an idea of, especially in the less frequent headaches, that where the CGRP antibodies may or may not fit into the role. If we then also look at the chronic headaches studies, and here the axes don't align because they were much lower for the chronic patients, we can see that it's also probably falls in the same ballpark. So again, I don't think it's something that's going to be an outstanding takeaway. So how do we put this in? Well, we probably should say the older medications, where there's the tricyclic antidepressants like amitriptyline, the anti-epileptic devices like topiramate. Some people look to use blood pressure medicines. Personally, I worry about the asthma effects and the depression effects. And if that doesn't work, consider going to another one. And if that doesn't work, that might be where the CGRP antibodies fall in. There are some pharmaceutical caveats we need to worry about. Is just because they haven't been approved for kids, that may mean the studies aren't done, so they may be not effective. There may be additional side effects that we don't know about. So I still think it's vitally important to do these studies in children and adolescents to get both of these answers, especially the safety component to it. Serena and I have actually written an article together, as well as our co-authors, that looked at the possibility of CGRP antibodies effects on the developing body and the developing bones that may be risk factors we need to evaluate. So what's one of the key components we really need to do is we get back and the future holds what the past has taught us, which is that really healthy habits, getting enough to drink, avoiding caffeine, exercising regularly, eating healthy, and making healthy food choices, especially green stuff that may have folate in it, and getting enough sleep. And then potentially adding the biofeedback and cognitive behavioral therapy. One of the issues that does come up over and over again, and sort of this last section of my talk, is to talk about the placebo effect. This is the placebo or the active response for the amitriptyline and topiramate in our CHAMP study. I took this data, overlaid the adult data in the larger groups, which include Botox, the CGRP antibodies, as well as topiramate and Depakote. And Serena actually helped a lot with this when she was a fellow. And we can see this sort of response pattern that occurs. If we then take the placebo and overlay it, so these are all just the placebos from all those studies, you can see they also are responding well. And when we put everything together, we can see the dashed lines and the solid lines are all mixed together. What that really tells me is there's a large effect, whether it's adults or kids, with the exception of the one topiramate study, that does influence the outcome. And why is this? The pain world has helped us a lot with this. And it's really the expectation response. So if the person expects to get better, they actually, and I'll zoom in on this, these are P factors there, and you can follow the lines. But on the left is how much they're expecting to get better. In the middle is the global impression of change, how much they actually change, and then what are the F aspects. So the bottom line is it gets to the art of medicine rather than the science, is that through working with our children and adolescents, that expectation response can improve things. If we look at other outcomes, and in the interest of time, I'm going to just flip through this quickly, but I do think future studies will involve a different way to look at studies. And we have started to do that. In our CHAMP study, we looked at the trajectory of response. And this just looks at a daily risk of having a headache. During the baseline, the daily risk did not change, but it actually started to change fairly quickly. If we tease that out into the 3 different arms, we can actually see it's a bimodal response pattern. And so that really we need to see most kids back in about eight weeks or so, whenever we start a medicine, because it depends independently of the medicine we start, that seems to be the trajectory of the response. The other outcome I think we really should shift to is, instead of looking at what's the percentage response, how many kids get a reduction of 1 or 2 headaches per month compared to placebo, is how many kids actually get better. So how many kids get down to less than 1 headache per month? Using our cognitive behavioral therapy plus amitriptyline study, we were able to show that within the 20 weeks, which was the design of the study, they did get better, and by the end of 12 months, they stayed better. So the outcome, the final outcome, and as we're getting to this, is that when we looked at a 3-year follow for a CHAMP study, not only did we make kids better, whether it's by frequency of headaches or by disability, but after 3 years, they stayed better. Other outcome measures that I'm not going to go through, but we've looked at is extending it past up to 5 years, how it impacts their transition into young adulthood, and how we can leverage technology to accomplish that. And finally, not going to discuss progression, but have put this hopefully together for you. So where do we go from here? I think we do know, and what I've hopefully in this whirlwind tour been able to show you, is that the response for kids is similar to adults, whether it's the acute treatment or the prevention treatment. But our real goal is to try to get kids down to less than 1 per week. And we've got a lot more, but a lot still yet to do to be able to accomplish some of those goals. Expectation is something I think we can really take advantage of and leverage. And one of the questions that does remain is, what about those kids that don't get better? As part of that treatment, oftentimes people come to us because they need to do something. But my viewpoint is the patient needs to help choose what that something is. And it may not actually be what is done specifically, whether it's the amitriptyline or topiramate or new agents, but that the introduction of the healthy habits and getting them past that hurdle that makes them better. And that if we really can help enhance that expectation, the long run is that they do get better. So in conclusion, migraine is common in children and adolescents. Diagnostic criteria can help us guide that development through the developing ages. Children need to be active participants in this involvement, and new and novel study designs may help evolve that. I do need this wasn't done on a silo. There were lots of people that were involved, including those of us at the Headache Center at Cincinnati Children's, as well as collaborators across the country and across the world. So again, I want to thank you for inviting me. I think I filled up the hour pretty closely, but I'm going to be sitting around for most of the morning if there are any other questions that come. But thank you very much, and I'm honored to be invited, and I just wish I could be there in person.
Well, thank you very much, Dr. Hershey. This was an excellent presentation and overview. I'll just go over some of the chat. I don't know if we have to speak to a lot of it because Serena answered some people's questions. So I'm not going to pronounce it properly, but lasventitine. That was Serena was saying they applied to Health Canada here, our equivalent, FDA equivalent, and they said they was not approved, and there's no immediate intention to resubmit. And I think Serena poked around to try and find out what the reason was, and they didn't really tell her, but it sounds like it was a labeling issue. And there's also a question about neuromodulation, and Serena answered it a bit in the chat, but I think Serena's going to touch on neuromodulation a bit more in her talk. So, I mean, we will just defer those comments for now. There was one comment from Dr. Buttle. I'm curious your thoughts on this, Dr. Hershey, as well. So Dr. Buttle is one of our residents. She said, a lot of acute and emergency migraine pathways triptans are after a bunch of things, fluids, ketorolac, Maxaran, etc. And then so there's going to be a delay there. And of course, as outpatients, we say immediate treatment. You want to treat as soon as possible with an abortive medication. So I guess, Sarah's question was, does that make sense in terms of having triptans kind of so late in the pathway for emerge, or is that because it's going to be several hours after their headache onset? So just kind of your thoughts about that and where they should fall. And Serena has kind of pointed out some of her thoughts in the chat, but I'm curious about yours.
Yeah, so I think that I actually don't think triptans should probably be used necessarily in the emergency room. I know there's some conflicting evidence with that, but the reason I don't think so is based on that development of allodynia aspects. For those of us that use triptans in kids, especially those that have allodynia, they'll tell us if they wait too long, it makes the headache actually worse. And there's a good explanation for that Rami Bernstein has worked out, and that's due to that activity-dependent versus activity-independent component. And when the headache reaches that activity-independent level, meaning it's no longer dependent on the peripheral involvement, the triptans have less efficacy. And so using them later in the headache is probably less component and less beneficial, especially if they have allodynia. Now, if they don't have allodynia, potentially they do have that benefit later on. I do think that if somebody does come to the emergency room with headaches because they've had a refractory headache at home, that for future headaches, the consideration of a combination of NSAID and triptans would be useful. But our sort of strategy of approach, and this is a whole nother talk, but our emergency length is if somebody, and I've learned from Serena, you guys call it emerge, we call it ED, but the same thing. If they show up for an acute headache in an infusion center, we start with a combination of the dopamine antagonist, the ketorolac, usually an IV fluid, and what we're trying to move much more rapidly to, if they're unresponsive to that, to switch to DHE or dihydroergotamine. And we're finding that switch, and one, it shortens the length of stay if they get admitted because they've already gotten their first dose. Oftentimes in the past, they don't get their first dose until they arrive to the floor if they're going to be an inpatient. But we're also finding a fair number will have an immediate response and be able to go home from the emergency room. And so our most recent fellow is putting that information together in our data sets. She's now in faculty down in Memphis. We'll hopefully have that information out so people in the world can utilize it. But I don't really think there's much of a role of triptans in the emergency room. Now, I know there's been some good studies that have shown that if somebody arrives right to the emergency room and they've never been had a triptan, that potentially giving to them can prevent the need for using IV infusion or therapy. But I think the flip side is it can also make it a lot worse for them because of that balance and activity independence. So they've shown up, they've made the effort to come to an emergency department. We might as well throw things at them that we know have evidence of working. And many of the dopamine antagonist studies have actually come from Canada. So a lot of the prochlorperazine studies, you guys have really helped out the world a lot with showing how effective they are.
I think we'll just do one more quick question. There's a question from Dr. Lamontagne about Botox and nerve blocks, but maybe Serena, are you going to talk about that a bit? Yeah, so we'll defer that. But there is a question from Jason Berman. Dr. Berman's the head of our research institute here, and he's asking, are there efforts being made to match therapies with some of these genetic polymorphisms for precision health-based therapy? So maybe we'll just end on that question.
So that's something we've been talking about for probably 15 to 20 years as we understand it. The complexity there is migraine really is a polygenic disorder. And until we really can sort out the alignment of the gene treatment interactions, we're probably not going to be at that point. It's a hope, it's a future hope that we will recognize it. And I really truly believe, and that's why those 4 tables of genes I showed you, that we focus migraine as a single disease. It's actually probably a single disease with multiple causes. And as we're able to understand those independent causes and factors, new designer treatments will probably come in play. Now saying that doesn't lessen at all the importance of healthy habits and the global effect. If you can make the brain healthier in general, you probably lower the risk factor. But if we can component in probably the closest approach that's been done, and it's not been well controlled, is in adult women that tend to have a strong menstrual component is trying to alter their menstrual cycle to affect potentially the estrogen progesterone component. The reason I say it's not well controlled is that I would like to see looking for those estrogen polymorphisms and directing them appropriately. There are a lot of risks to that. Estrogen therapy in patients with migraine with aura increases their coagulopathy, which potentially then you're treating them with an estrogen supplement to help their estrogen system function, but you may be giving them a stroke at the same time. So I think that the future line is that we really need to understand the genes better to be able to direct the therapies better.
Well, thank you very much again, Dr. Hershey. This was an amazing talk. We're going to move on to the next presentation, which is from Dr. Orr. And so hopefully everyone can stay for Dr. Orr's presentation.